Good morning, Chairman.
Good morning, and good morning all, and welcome to this meeting of Adults and Community Wellbeing Scrutiny Committee. I would like to welcome the members of the public who are listening to the audio feed via the County Council's website. I'd like to confirm the members of the committee who are present. Rachel Wilson, Democratic Services Officer, will ask members of the committee to indicate their presence after their name is called.
Thank you. Chairman, Councillor Marfleet.
Present.
Vice Chairman, Councillor Mrs. Sneath.
Present.
Present. Sorry.
Thank you.
Yeah, thank you.
Councillor Adams. Councillor Mrs. Ashley Morris. Councillor Folkes.
Present.
Councillor Kendrick.
Present.
Councillor Mrs. Lawton.
Present.
Councillor Mrs. Overton.
Good morning, everyone. Present.
Councillor Reid.
Present.
Councillor Whittington. Thank you, Chairman.
Okay, thank you. So, well, I would anyway welcome everyone, and good to see you all here on this sunny day. Is Councillor Bradwell in attendance, or?
I don't believe she is.
No, I think she was struggling to get here today, but I know Glenn's here, so welcome, Glenn. And I'd also welcome all the other officers present, and they will be introduced at the beginning of their items. So we'll start off with apologies, please, Rachel.
Thank you, Chairman. We've received apologies from Councillor Mrs. Kelly.
Thank you. Declarations of members' interest. So if any members have got any interests or feel that they have when we are in the agenda, then please let us know. Minutes. To confirm the minutes of the meeting of the 24th of February 2021 as a correct record. First off, can I ask for a proposer and a seconder?
I'll propose here. That's Councillor Folkes.
Thank you. And a seconder? That Liz. Yeah.
It can be. Yes, I was trying. Yes.
Right. Excellent. Thank you. So, can all members of the committee turn on their cameras, and can all those in favour please raise their own hands for? That looks like everybody. Any against? And any abstain? No. Okay. Rachel, can I just Mark Whittington is here on the screen, so I don't think you got him on the attendance.
Thank you, Chairman.
Thank you. So I confirm that the minutes are approved, so we will carry on. Announcements by the chairman or Glenn Garrard. I have none at present. Glenn, do you have any comments that you want to make at this point?
Thank you, Councillor Marfleet. No, nothing from me. Thank you.
Thank you. So we'll go on to item 5 then, adult care, occupational therapy. We've got Gareth Everton, Head of Integration and Transformation, Adult Care and Community Wellbeing, who is going to lead on this item. Morning, Gareth, and welcome.
Morning, Chair. Thank you very much. It's a pleasure to be here and able to provide the committee with an update on the Adult Care Occupational Therapy Service. I do have a presentation. Would you like to share my screen and go through it?
Yes, please.
Grand. hopefully when you don't get any technical issues.
We wish.
So could somebody confirm they can see that?
Yes.
Great. And just to say, how I've got my screen set up, I can't see if any comments or any hands up. So do just stop me. Otherwise, I've a tendency just to kind of rattle through things. So yeah, I'm Gareth Everton. I'm the Head of Integration and Transformation. I'm also an occupational therapist, and I have the Head of Service Responsibility for the Adult Care OT service. I do touch on the DFG, the Disabled Facilities Grant, throughout this report, but I do try and focus on the OT side of things, and I'll touch on that in a bit more detail. I've done this before, gone through a presentation and realised that the slides aren't changing. So again, could someone just check that you can see the slides gone? Great. So there is sometimes an assumption that all occupational therapists are the same. And I think in some of the committee meetings I've been to where people perhaps didn't know that we have OTs that are employed by the NHS in Lincolnshire in a range of different services. So we have OTs in adults and children's services in LCC that are run very differently, but we also have OTs in the hospital, in the mental health provider in LPFT, in community health services in LCHS, and increasingly in different areas like the hospice at St Barnabas and also increasingly now in primary care networks. And they all have slightly different specialisms. So a bit like where someone will say, I'm a doctor, and we have a fairly good understanding of what that means. But no, there's a massive difference between being a consultant paediatrician to being an orthopaedic surgeon and a GP. It's not quite as diverse in that in OT we have key knowledge, skills and experience, but it wouldn't be unsurprising for an occupational therapist in working age mental health services to have no idea what a DFG is. And that would be appropriate in the same way I don't know a lot about running cognitive stimulation therapy groups. You know, there is a big distinction. But I just want to focus on the adult care service. And in that we have 73 full-time practitioners, and currently 32 of those are CCOs, and that's community care officers or OT assistant practitioners. From the time of this slide deck, things have changed slightly. We've had a recent round of recruitment, and we're now about 34, 35 CCOs, and I'll talk a bit more about skill mix later on. We are established in coterminous boundaries with the district councils. That's a fairly new thing. When we started the transformation, East Lindsey was a standalone team, but obviously through the strategic collaboration between East Lindsey and Boston, we took an opportunity to relook at that, and we have an OT service, a team that mirrors that boundary. We will have to review how we're set up with these four teams. So South Holland is a small team at the moment, but the lead practitioner there, Bev, she retires in 12 months, which gives us an opportunity to think about the East Lindsey, Boston, South Holland kind of strip of the county, about how we might be the best place to set that forward in the coming years. So as a service, we receive about 6,500 referrals a year, and as a kind of a group of referrals into adult care, that's roughly about 28% of the total referrals that come into adult social care. And just as a kind of point of reference, the workforce numbers is about 15% of the total whole-time equivalent across the division. So I think we are getting kind of good value from that 15% to deal with 28% of the referrals. And I don't want to get into the kind of debate about counting one social work assessment as one OT assessment. We are different professions and do things differently, but gives us an indication. And the average waiting time for assessment is currently 48 days. That doesn't include March activity, but I can't see that it has changed significantly from there. And if we include those assessments completed at the first point of contact, so a duty assessment, 56% of people are seen within 28 days, which I think is a really good figure. Through the report, you'll see that I mentioned about the development of a duty approach. And when we started this transformation, I had an idea that would be about a 15-minute, 20-minute conversation to enable people to go onto the right waiting list and understand risk. as it's transpired, as we've developed over the last 18 months, that is quite an intense conversation, can sometimes take about an hour, understand people's needs and try and resolve those at the first point of contact. Can sometimes take 3 or 4 weeks to get the equipment in place from NRS and to do a telephone review. So that is quite a significant undertaking. And I think it's right to consider that in the whole as a more comprehensive view about activity through the service. So in terms of the dashboard that we've seen, that has a granularity that we can
Gareth,
talk about each different ways. Yes, hello.
just while you're on about people's needs, can you just give us some examples of the different needs that you sort of are currently, just quickly, please?
Absolutely. So the majority of referrals that come through are for equipment and adaptations. So that could be something where somebody's having mobility problems and struggling to get on and off a toilet, for example, or managing the steps into the property or stairs. So as a general rule, the majority of referrals that go to our community care offices, our CCOs, tend to be ramps, stair lifts and level access shower adaptations. We have a catalogue of standard equipment that comes through NRS, so that could be toilet raisers, so someone can get a raised toilet seat to get on and off the toilet more easily, or a grab rail to go next to the toilet to help with the transfers. So those kinds of things. We do manual handling assessments, so when somebody needs a carer to help them to transfer, that's not a particularly good word, transfer, but that's what we call it. So hoisting somebody out of a bed or using a piece of equipment to do that safely. And then things like rehousing applications, and teaching people to do things in a different way. So sometimes it's not about changing the environment or providing equipment, but just doing things in a slightly different way means someone can be independent.
Brilliant, thank you.
Okay, grand. So like I said, in terms of the transformation project, that started back in 2019 and properly started on the 1st of November. But prior to that, it took a good 6 months of that diagnostic phase, having semi-structured interviews with people, attending the Moving Forward with DFG group to get a wider understanding of what our practitioners, our customers, our stakeholders felt was working well or not quite so well, to inform that case for change. And I think it kind of landed in 2 different areas, one around the form of the service and one about the function of the service. Now, the form, the restructure was relatively simple. So from the 1st of November, we moved into 4 teams, introduced a post of a principal occupational therapist, which we didn't have before, to provide some more operational leadership to the service. But the function is always more difficult. And on a good wind, could take years to do that kind of cultural shift. But obviously with the challenges of COVID, that's taken a little bit longer. But we've started to look at the functions of the service and from where we were before. So the OT team previously was part of our adult frailty locality teams who would undertake a Care Act adult needs assessment. On Mosaic, that meant we couldn't disaggregate what a social work assessment was from an OT assessment. It meant it was very difficult to run reports and to have clarity on waiting lists, whether somebody was waiting a social work assessment or an OT assessment. So what we did quite rapidly was did a fantastic piece of work with our Mosaic colleagues to design an OT workflow. So within 4 months, we designed, tested, implemented, trained and mobilised this new workflow. And what that meant was Daniel and Catherine from our Mosaic team came into the Orchard House on a Saturday, spent 8 hours transitioning workflows from one to the other. And at that point, we had a real understanding of what the issues were, that we had 800 people who were waiting an assessment who hadn't been allocated to a practitioner. And some of those individuals have been waiting longer than 12 months for that assessment. And clearly we needed to do something different. That root and branch review of all our processes to try and see what a standard operating procedure would look like, what a good service would look like. And like I said, clearly COVID-19 has impacted on that, but we've had some significant changes. And whereas some of our other colleagues in other services might have found their waiting lists have expanded, ours have reduced. People are being seen much quicker, and we are continuing on that journey, but not quite as fast as I think we thought we would have been. So the most significant point has been the development of a performance dashboard and the framework that sits alongside that, and that performance dashboard's in the pack today as one of the appendixes, and just kind of talk through that performance dashboard. So again, another piece of collaboration with Michelle Gregory, one of our performance and intelligence officers, and really looking at what information we could gather from Mosaic and how we could use that in different ways that we'd not done before. That coincided with some staff engagement events to really make sure that our OT practitioners owned the issue, owned the data, understood the impact of their way of working and what some of the solutions might be. And what we've been able to do with the data is to look at targeted service improvement activity as well as kind of demand and capacity review. So what I mean by that, in the performance dashboard, you'll see one of the lines around the proportion of cases resolved at duty. And what we found in the South Holland team was that initially 17% of cases were being resolved at duty, which was a bit below the average. So doing that targeted work with their duty practitioners, we've been able to increase that to the average of the 35%, the 40% of cases resolved at that first point of contact. When we established these teams initially, we had to use proxy measures to give us an understanding of where the demand might be and how many staff members would be needed in each of those teams. We've now got data to fully understand where the referrals were coming in, where the pinch points were, and what resource would be required. So what we've been able to do is to make some targeted decisions around the use of vacancies. So some of the occupational therapy posts have been converted into CCO posts because we understood that's where the waiting list were, and actually shifting them to where the geographical areas with the largest unmet demand. So that's been a really useful process. That should mean now after the latest round of recruitment, we'll see a bit more of an accelerated reduction in some of the waiting lists. I think one of the big challenges was around introducing the duty process, and that's been a massive success. So you can see 31% of individuals have their needs resolved at the first point of contact. Now, prior to this change, that's 31% of people, about 2,000 referrals a year, that would have had a face-to-face assessment that wouldn't necessarily been productive. So what we found with these cases is that in 30% of those, we've been able to provide community equipment over the phone. NRS have delivered it, and they've had their needs met with no further action. And the other 70% of people will have been cases like signposting to the wellbeing service or contact with the fire and rescue service around a risk assessment or a wellbeing assessment. Working with primary care or physiotherapists or those kind of other range of services around that didn't necessarily have to, wouldn't necessarily be best placed with LCC. And the concern around that is obviously if people are being turned away, that they genuinely have had their needs met with that information and advice, and that people aren't just delayed and coming back. So what we've done is a review of the last 12 months of the people who have re-referred. And what we know is 11% people re-refer once in that 12-month period, and only 2% twice, and really negligible numbers any further on from that. And 11% does sound, quite a lot. But when you think over a 12-month period and with the cohort we're talking about, a significant change or deterioration could have occurred in that time, and quite likely to have happened, a new diagnosis or a deterioration or a hospital admission that's needed something different. So in terms of wider performance, what we've seen over the last 12 months, the number of people being assessed within 100 days has increased from 62% to 92%, which is a real significant number. The number of people being assessed within 28 days has increased from 21% to 34%. But as I said, if you include the numbers of people who have had their needs addressed at duty, that goes up to 56%. And the number of people awaiting allocation has reduced from 800 to 550 people. So there's been some significant changes, even though in the background of the pandemic and the issues that's brought. So just to kind of touch briefly on COVID, and I don't want to focus on too much because we all know the challenges across the health and care system of that. But it did affect the OT service in quite a profound and an unexpected way. So we think back to this time last year when we had the stay-at-home order, problems with access to PPE and some reductions in access to the LCC network for that initial kind of working from home period, that our referrals into the OT service reduced by 35% in that 3-month period, March, April and May. Our activity was skyrocketed because we weren't doing face-to-face assessments. We were able to do lots of virtual assessments, but that almost moved the bump in the carpet further on. So each practitioner then had a number of people that they needed to see face-to-face when restrictions eased and it was safe to do so. When that happened, our referral rate then went up. So the 35% reduction we had came in the following 3 months in June, July and August. So we had that 135% referral rate, which really kind of built pressure along the service. At the same time, the system was under incredible pressure and our service was trying to support our health colleagues. So particularly around ULHT and at Boston Pilgrim Hospital, their OT service was down to about 10% capacity, with a significant number of people who had COVID symptoms or had to confirm COVID and couldn't work. So we were able to provide arm's length support to the non-qualified staff, and what may mean that is healthcare assistants or nurses around occupational therapy intervention to keep the flow out of Boston Pilgrim happening. Similarly, from an LCHS perspective, our community health provider, they provide a service to people with long-term conditions. Well, their focus had to be on preventing hospital admission and facilitating people in terms of flow from short-term care or transitional care beds. So we were taking more referrals for people with long-term conditions. And there was an increase in moving and handling referrals associated with the discharge to assess pathway from the hospital. So what we found is once people were medically fit for discharge, within 2 hours and an hour, people were going home without necessarily having the OT intervention finished at the hospital. So it meant we did have to respond in a different way to people who potentially being cared for in bed, discharged from hospital, to allow the home care agencies to work effectively. Now, it's not all doom and gloom around COVID. It certainly has provided a lot of opportunities around accelerating some of our plans around a virtual first approach. So that's something we want to continue with longer term, is that everybody has a phone call and we talk through as much as we can virtually, and then the time spent in someone's house is much more targeted on things you can't do at arm's length. And testing the style of supported self-assessment. So people taking photos of the bathrooms, for instance, and emailing those across and what we can do with it at arm's length. So back into the performance dashboard, I've just brought out some of the information just to kind of focus on. And in this slide, you can see the numbers, the assessments completed within those 28 days, 56 days, 100 days, and how it's improved over time. The graph, it does show that kind of bump in the summer where we spiked activity, then had to catch up as referrals doubled. I am happy to say that in March, that upturn continues. So we are back on the upward trajectory and getting back to where we want to be. So I said I'd touch on Disabled Facilities Grant. I think there is something about, imagine it as a Venn diagram, where you've got the district council's housing responsibilities, covers a lot more than DFG, but there's a sliver there. And similarly, OT covers a lot more than DFG, but there's a significant overlap in how we work with the districts on delivering DFG. And all our OT practitioners and CCOs are aware that there's a financial element to the DFG process. We don't make that determination. So we'll identify somebody's need, that there's a need for a ramp, a stair lift, a shower, etc. But actually the district council will do the means test, will consider discretionary grants, the regulatory reform order flexibilities and whether that work happens or not. And looking at the data that we now have on Mosaic would suggest that 48% of applications do not progress from that referral stage. So that's people who, as an OT service, we've identified there is a need, but for whatever reason that does not progress into work. Usually that will be somebody's unfortunately passed away, moved into a care home, or there's been a significant change in their presentation. But there will be some of that where somebody's financial assessment, their contribution is so much that they aren't able to continue through the DFG process. So in terms of the OT service and DFG, we're working with the district councils and our public health team and LCC around the DFG pathway. And there's a number of work streams going on at the moment. So there's the Centre for Ageing Better work, and one of those work streams is around housing and maximising independence. I know at the last Scrutiny Committee I had the Housing for Independence blueprint, and how this all sits together from thinking more away from DFG equipment, OT as separate work streams, to being a more holistic view of maximising safety and independence in the round. And finally, I was just going to mention that we've been doing some work on trialling an approach in East Lindsey around a housing partnership meeting. So lots of different partners sharing information, some of the challenges, sharing the solutions, and that's been really well received and made a significant impact. And it's something we are ramping up, working with partners across the county. So just to kind of summarise, bring this all together, so the OT service is approaching the end of a 2-year transformation project, and we have the framework to support best practice, which was an appendix to the report, and the performance dashboard that shows the journey that we've been on. So prior to the transformation, people could wait a year for an assessment, but it's now 48 days, and 88% of people at the last count are being assessed within 100 days. That's slightly improved, taking March activity into account. But we know we're not at the end of that journey, and we continue to have projects and service improvement methodologies to try and meet that target, that no resident of Lincolnshire is waiting more than 100 days for an occupational therapy assessment, and that 50% of people are seen much quicker within 28 days. There is no nationally benchmarked data, but we know that we do compare really well, in that we're thinking our waiting list in terms of days and months, weeks and months rather than months and years. And that work continues with the district councils and public health around the DFG pathway. But we're making great benefits from working in coterminous teams. And there'll be a more substantive DFG item to come to a scrutiny committee in due course. So that was the end of my presentation. Let's see if I can stop sharing my screen.
Well, that's very good and in depth, and the report's got a lot of information in there, and I think actually, it's well, you can only actually say, well, from my perspective and views, is that it's a journey that has been well worth transforming, and I think the outcomes are brilliant. I think, some bits are going to develop better because you've got everything in place. So 2 years is quite a long time, but it's a long journey, and I think that the sort of the next year it'll evolve far quicker as well. But I will open it up to the floor first, and I've got Councillor Rob Kendrick who wants to speak.
Thank you very much, Chairman. I just wanted to ask, as regards the appointment of the principal OT. I'm going back a bit now, but when I worked for an NHS trust, the chief exec was a psychiatrist and had a caseload, so he had patient contact. But unfortunately, the lead OT, as she was called, had no patient contact, and yet she did clinical supervision of OTs, which, working with OTs as I did, they were a bit surprised that she was totally out of touch with current practice, and yet she was supervising them. I hope that the principal has at least patient contact, even if she doesn't have a caseload.
So yes, thank you. I think you're absolutely right. It's really important to keep that patient contact. So unfortunately, it's how cases are escalated to the principal occupational therapist. So she doesn't have a caseload, as you say, but will support. So I know recently she did an assessment for somebody who had a non-traditional construction house, needed a bit more. So she absolutely does still keep her hand in.
That's excellent news, because so often in services you find that the senior management haven't got an experience of what it's like on the ground. So that's brilliant. Thank you very much for that. Thank you, Chairman.
Excellent. Thank you. Got Councillor Christine Lawton.
Thank you, Chairman. Just to say, as a district councillor, I really welcome the involvement with the districts. I know at South Holland we're very pleased, and just thank you. I think it's the way forward. We're all one county. All our residents have the same issues and problems, and I think it's a really good result. Thank you very much to all involved.
Thank you.
Thank you. I think I've got Councillor Liz Sneed next. Yes. Get every other thing in my screen. I can't see who's what.
Thank you, Chair. Yeah, thank you. That was interesting. Masses in there. I'm very involved with this at the moment on a personal level with my own family. But I think perhaps what we've got, well, I feel this, I don't know if anyone else feels this, a little bit of a branding issue with occupational therapy. You know, I probably come from a generation which thinks occupational therapy, that's someone coming around to your hospital bed teaching you how to do raffia work. I don't know that occupational therapy describes what you do. And I think it's time for a rebrand. I've been working just lately, because of this family issue, with the reablement service. That's perfectly self-explanatory. Everybody knows it. DFGs, once you know what those initials stand for, that's it self-explanatory. But OT, I don't think it is. I'd like to know your thoughts, Gareth, actually, on that. Thank you.
Thank you. That's a really good point. So I've previously been involved with the Royal College of Occupational Therapists. I've been on the board, and I'm standing for election again this time round. And what they've been trying to do is to look at that rebranding and the use of strap lines, and had some people in. There is a large promotional campaign that's been going on. But obviously, I think there's been other priorities. So last year it was around saving money, better choices, something like that. So there was a couple of campaigns, one around social care and how we could do things differently to maximise independence and focusing more on outcomes, and some best examples. The problem, of course, is people who are interested read that kind of documentation. People who don't have a need ignore it. And I suppose it's how you raise the profile of the profession much wider. But I completely agree, occupational therapy doesn't roll off the tongue and doesn't really describe what's in the tin.
It doesn't. No. Thanks for that.
Hence why I asked you what you did, because I was thinking, I agree with you, Liz, on this. You're just used to it sort of in effect being a massage, getting the body going.
Yeah.
Type thing.
So,
excellent. Well, I've got Councillor Mark Whittington.
Yes, thanks, Mr. Chairman, and thanks, Gareth, for a very interesting presentation. Just one question. I appreciate it. Obviously, it might be difficult at the moment with all the sort of pressures that COVID has caused for services. I'm really pleased to see that there's been a big reduction in the waiting list, and especially the number of people waiting more than 12 months, which I think is really important. Just the question is, obviously, there's always going to be people on a wait list for any service. Just your thought as what you would think would be sort of the acceptable normal number of users awaiting an assessment, and how long do you think it potentially could be before we approach that sort of level? And I know it's difficult, because we've got all the COVID stuff hanging around at the moment. Thanks, Mr. Chairman.
So for me, there's something about I'm a resident of Lincolnshire, and I have family in Lincolnshire who need occupational therapy assessments, and what I would expect and what I would want for them in terms of referral to treatment times. So for occupational therapists in the NHS, that would be 18 weeks, which clearly isn't what we want. And I think we would, by saying 100 days, which I think is 14 weeks, has been our expectation that nobody should wait longer than that. I think we are ahead of the pack. In terms of some of our neighbouring authorities, they are years, and you could be 2.5, 3 years sometimes for an occupational therapy assessment from a local authority, which is completely inappropriate. I would like to say that we could see people within the 28 days. Our target will be that 50% of people are seen within 28 days. And I think that would be a combination of, I hate to say it in this phrase, but some of the easy wins. So where it is straightforward piece of equipment, a minor adaptation, we can do things quickly, then great. There will be some complex, urgent cases that we have to prioritise and do things quickly. But I think definitely the 4 to 8 week would set us in a very, very favourable position against any other neighbouring local authority for an OT service. I don't know if Glenn wanted to come in and have a view on that.
Just before he does, I'll come in on that as well, actually, because perhaps tie in. I agree with Mark on this, and I think we all agree. Time is of the essence, and 28 days is actually, if you're in a sort of discomfort, is still a long time. And I suppose my view is on this is, do we do like a sort of, because in essence, the bit that you actually mentioned at the beginning there is virtual first approved. I think is essential. I think we're now getting into the world where you can sort of FaceTime, you can do all sorts, send photographs from the phone, everything's so much easier that actually virtual assessments is a very quick way of speeding the process up. And in effect, the style of supported self-assessment which ties into that, and then which then in effect goes into what I would call like a sort of, I hate to say the word, like a risk assessment, i.e. if somebody just needs a high raiser for their toilet, actually that should be done within 2 weeks with not even waiting, because that's just an application. Now, if somebody needs stairs altering to get in and out their house, actually that can't quite be done so quick because it has to be assessed. And I suppose, does that form into the equation? Because we don't want people waiting for 100 days if actually all they really needed was a grab rail in the toilet or something that's really very quick and easy to do.
Yeah. So no, thank you, Councillor Murphy. That's right. That's the process we put in place where everybody has that phone call, initial conversation within 4 weeks. Everybody. And there will be exceptions where we don't get the right information in that conversation, and there might be people that fall through the gaps. But those straightforward bits of equipment, easy to do, are being done within weeks rather than certainly within months. It will be the cases where we need a face-to-face to measure, to see, to touch people. There'll be the cases that are waiting. Yeah.
Yeah. So, do you want to say anything, Glenn, on?
So thank you, and well done, Gareth. That was a good presentation. Well done. I know that Gareth put a lot of work in, members, to get this, because there is a lot of information, and it's not always easy to condense it. So a few things for me. I think the first is that you'll have got a sense, I think, from Gareth, of the level of ambition, because we want to be the best in the country for this kind of area of activity. And it's also a big area, 6,500 people a year. That's significant. I think the other challenge that we've got is, as Gareth has mentioned, there is no national benchmarking available to us. And it's a real weakness, because we can think we're good and we've got some material that tells us we are and getting better, but we don't know what the actual best looks like. But the more we try, the more likely it is that we're going to get to a point where we are one of the best in the country, if not the best, and then expect that the national data sets, when they do come, will help illustrate that. I should also remind members that the government intends a process of assurance on social care in the future. So our ability to talk about areas of really good practice, I think not only illustrate where Lincolnshire's ambition lies, but also will help the sector as a whole improve, because the Care Quality Commission, who will lead assurance processes for the government, will be reporting on good practice as well as those councils who need support. And then finally, if I might, it's where does the service go in addition to what it's doing, and the use of digital technology, the opportunities to provide people with some facilities for self-service are all things that we're beginning to explore, because there are people who do not need an assessment to receive some items of support. And the more we can help people help themselves, the more likely it is that the people that we've got working in the professional groups will have more time to devote to those who need us for longer. Thank you, Chair.
Brilliant, thank you. Well, I'll come back actually now on a couple of bits which are actually relations to you, Gareth, and to Glenn. I do think this is really good, but when I've gone through it, there's a few areas which I think are sort of, if we're not careful, we end up in sort of no man's land. And I'm not saying this service. So for argument's sake, it talks about Lincolnshire Community Health Service, who's shifted its focus of admissions avoidance to supporting, at the expense of supporting people with long-term condition. And I'm seeing an overlap potentially, and I'm not quite sure if there is or not. The other thing, which I think is perhaps what, when we're sort of just speaking about it, Glenn, in essence, where we've got the wellbeing service, there is a sense here that we've got sort of, and this in a sense is sort of part of the wellbeing service, and it's not part of the wellbeing service, but it is in effect that prevention service and reducing greater impact on other services, which in some sense, and I sort of half wonder whether there is a point where, as we look to the future with changes, that these sort of things, we perhaps in effect, there is a sort of overlap or rebranding sort of at some point, maybe with where everything sits a bit more. That's perhaps more to you, Glenn, on that one.
I think you've just made Gareth a very happy man, Chair. So a couple of observations, and in some respects it's a segue into the next item for the committee, which is in the next administrative round, there will come a point where members will receive a further update on the occupational therapy service, and we'll ask the question, where next for the service? Because as soon as you get to be good, you have to think about, okay, what else are we going to do now to stay in that position? And it isn't just by doing more of the same. I think one of the key questions for the next committee will be, what does integration with health look like across the range of services that the council provides, not least my own? And we know, as Gareth has indicated, that there are OTs in the NHS who, shall we say, we might do better if we joined up the dots on this service. And if the county council's got a really good service, then it's in a much stronger place when it comes to redesigning with our health colleagues what the future might look like.
Yeah, and I think what with perhaps the white paper and I think now that we're sort of seeing the back of all the issues of Brexit, COVID, I would hope that I think the government now will want to throw out sort of some reforms. And I think we will be targeted. And I think it lends itself to what we've just been speaking about. And I think what we've also spoken about today, in effect of all the notes I've made for the next item agenda, a lot of them are actually already been mentioned, which is about digital, IT, integration. And I think it's I think COVID's highlighted a lot of this and helped to speed up that sort of process as well, hasn't it? The fact that we've had to change. So, well, I think you've got...
Sorry, Councillor Marthy, can I just the point around that kind of duplication of services with LCHS, and just want to say my principal occupational therapist right now is having a meeting with the lead from LCHS around what we don't want to do is to wait for kind of national guidance to do things.
Yeah.
And what we're looking at is how we can kind of share referrals and confirm which is the right organisation to work with that person. So it's not necessarily people referring to LCHS and LCC and who gets there first. It's about the right organisation at the right time. So we're definitely working on that as we speak.
Brilliant. So I've got Councillor Rob Kendrick to come back.
Thank you, Chairman, for allowing me to come back. Just to wish Gareth all the best with his election to the college, and perhaps when he's elected, he might lobby for get the college to lobby government for some standardisation across the country, as we've been discussing earlier about the sort of criteria or the benchmarking issue. So just wanted to say best of luck to Gareth, and I do have some understanding what OTs do, so I have every respect for what Gareth and his colleagues do. Thanks very much, Mr. Chairman.
Thank you. Yes, well, I wish you well on that, Gareth. So, and I think, you've got an exciting year ahead.
Thank you.
And just hope I'm back to see it. We've got our own. So, anyway, well, thank you very much for that. And we look forward to seeing you in the next session.
Thank you.
Excellent. Right, well, we'll move on to the next item then. So item 6, the forward work programme. Hello. Welcome. First time we've seen you.
Good morning, Chairman. It's good to be on board. Thank you. Good morning, everyone. My name is Chiara Kadzioanu. I'm the newest scrutiny officer in the team, and I'm here to present you this report. Now, this report sets out a draft work programme for the coming year. The draft programme has been based on the anticipated timings of standard items, such as budget and performance monitoring reports. The committee today is invited to make suggestions for items that could be included in the committee's future work programme. And if you turn on to page 49 of the pack, you will see that over the last 4 years, the committee has on average considered between 3 to 4 items at each meeting, and that all meetings have averaged just over 2 hours and 40 minutes in length. Now, any suggestions from today will be reported to the newly formed committee and its first meeting in the new council term. Thank you very much, Chairman.
Thank you. So, well, I suppose one of the key things that's going to sort of potentially come in is these white papers. So, Glenn, do we have any ideas of potentially how many white papers we think might be coming? Or
Thank you, Chair. The latest count would suggest about 5, possibly 6.
Right.
And the reason for that, I think, is in part because the government's legislative programme during 2020-21 was delayed in order that the government could focus on dealing with the COVID pandemic. What that means, though, is that when we look ahead to this coming year, that legislative programme is now far busier than it would otherwise have been, because it's all bunched up.
Yeah.
We've already had 2 white papers, one concerning mental health, and one, the health and social care white paper. I think later this year there are future papers on procurement, how we buy things, that's also affecting the NHS. The white paper on the future of social care, which I'm a little involved with in the national role that I've still got. And I think also we can expect to see something around the deprivation of liberty standards, which are planned for implementation in 2022, and they've been delayed 4 years now. So I suspect the government will want to implement them on this occasion. So a busy year ahead, Chair, both for the future committee and for my area.
Excellent. And when you mentioned about the future with the social care white paper, I presume what they'll do is bring out the health and well, it's out now, but bring out that deal with the health and social care as an integrated, and then basically then the social care one that comes out will be what is sort of in effect not part of the integration. Would that be right?
Yes, I think we can expect that what the government's reforms for social care might include. We know already from the Health and Social Care White Paper, it will include something on assurance.
Yeah.
Ministers will want and expect more leverage on social care in the future, and that's likely to include a stronger mandate for national reporting. So Councillor Kendrick's point about occupational therapy and getting the government to, as it were, push harder to get a standard reporting template is probably something that we'll be able to influence. We know that the government will talk about digital in social care as it has in the NHS. And my guess, Chair, is that both the Department of Health and Social Care and the Ministry for Housing, Communities and Local Government are likely to want to say something about housing for the kind of people that this committee would be concerned with in the future, disabled people of working age, older people, and so forth. And current national policy doesn't really talk to that space. So I think there's a number of elements in there, along with how better to ensure we've got a skilled and sufficient numbers of the workforce. We've got 21,500 people working in social care in Lincolnshire. That number's going to have to grow over the next 10 to 15 years to meet future needs. And the government has a role to make sure that we can, as it were, look at the workforce and identify those things that would make it more attractive and also would help retain people in the sector. I'll leave it there, Chair.
Brilliant, thank you. So, well, I think, I suppose we can sort of potentially list that for the next session with some potential dates, although we don't necessarily know on all of that, but it's worth just having it there as a reminder what is potentially coming forward, and it'll be altered as we go forward. From sort of ideas of sort of key areas, has anyone got any comments that they want? I think the sort of digital and IT sort of does sit on the agenda because that's going to be part, and sort of that sort of links in with assessments and other bits. Other areas I've sort of put down is the sort of, well, the whole umbrella of sort of well-being and OT, etc., and that sort of, I suppose, DFG. It's all part of prevention services, isn't it? Which and the one new Lincolnshire and the public health and all of that. I mean, the prevention has to become a priority and keep being a focus. Is, I suppose, a view. So, Glenn.
Thank you, Chair. In addition, and I do think the committee is going to be busy in the next session. We've got some significant procurements underway that this committee will have to take a view as they will be decision notices. Two of those. First one is residential care. That's probably the single biggest procurement in terms of finances that we have, and it'll be hopefully a multi-year settlement.
Yeah.
The second will be home care, which is the second largest area. And then we're also looking at carers services and equipment services as well. So quite a few procurements will come forward for committee's consideration in the next year as well.
Can we sort of try and get some of those procurement ones slotted in on the forward plan? Because I'm mindful that, as you say, some of those are big topics. And I like what we've already got in the forward planning already. And I think that we know that there will be movement, but it's no bad thing to have some form of penciling in, because at times, if we're not careful, we then sort of, there's a timing about when we should look at, whoever should look at other things. Otherwise, we overload the agendas when actually, potentially, we know, like you say, what procurement are finishing next year at some point, and we will go out to re-procurement. And so I think we ought to try and sort of slot them in, at least because that's what it's about, isn't it? Is trying to just make sure that we are aware, and that in effect the committee manages its own workload. I know how easy it is over the last 4 years, where we all get sort of wanting to look at this and that, and all of a sudden actually we have overloaded our own agenda very quick and easy. So that's good. Liz?
Thank you, Chair. I'm sure we'll all like to see something about post-COVID issues. Particularly, I'm concerned about mental health, and I expect we'll get updates anyway. But I think it's important we leave space to discuss outcomes and how things are going. I think we've got to keep ourselves relevant, haven't we, to what's actually going to be going on. Thanks.
Yes. Yeah. And that's why I think we get some of these procurement things in, so it just helps us. It's a guide, isn't it? And I suppose other areas on the back of that is like volunteers, because I know we're sort of trying to sort of connect better with that whole organisation. Some of these are quite challenging.
Thank you, Chair. So there is a lot of work underway at the moment to ensure that the level of volunteering that took place during COVID isn't lost.
Yeah.
And also that we learn from that experience of supporting the 51,000 clinically extremely vulnerable, which was typically a large group of people that previously we would not have had that much involvement with. So that's also a preventative potential for us. And at the same time, trying to help the voluntary sector, which is very diverse, to come together to speak with one more powerful voice. And with my health colleagues, we're supporting them to do that. So that would not be a problem at all should the next committee want to have a presentation on that, possibly introducing some of the leading lights in the voluntary sector as well.
Yeah. And I suppose the other thing, of course, which everything hinders on, is the Better Care Fund and all the financial elements that have to come our way to support everything.
Yeah, thank you, Joe. That also might be a white paper.
Right, yeah. So, is there any other comments anybody's got? I think you say mental health is part of it. Well, I think there's quite a few little bits there that can go forward. I look back at sort of a lot of that we've done, and it is about sort of, in some sense, we've done what I call the strategic, having a look at the overview of everything, and then we've deep dived down and looked individually at some of the services, and I think in essence we see a sort of really the complexity of the world of adult social care over the last 4 years. And I think, and when I look back, I take great pride in the way our sort of adult social care team and public health team are working and striving to be the best. And I think, that is very much, I think we see that quite clearly. And I sort of congratulate everybody that's involved in and around our sort of adults and community wellbeing at the council. I've got someone that wants to speak. Someone's got their hand up.
It's Councillor Whittington, Chairman.
Right, okay. Mark, are you there? Or right, hi.
Yes, thanks, Mr. Chairman. It's something that just sort of crossed my mind listening to the comments that Glenn was making about sort of working closely with colleagues and other agencies. Obviously, the next sort of few years we're going to see the development of these sort of integrated care systems, and the potential that some finances, some budgets could be pulled and shared with the local NHS. So I just think that that maybe the committee going forward, that could become quite important for them to look at and to have a handle on. I mean, as you know, I've worked as an accountant in both the NHS and local government, and I certainly, shall we say, have a slightly more faith in the ability of local government to control its budgets than the NHS, and I can see Councillor Kendrick having a bit of a smile to himself as well. Thank you.
Excellent, thank you. Liz?
Thank you, Chair. Since we're coming to the end, I just want to make a personal comment, actually. Thank you for all your help and support and all the officers. But equally, I want to just comment on something that's been happening to me lately, which I've been using adult care very much. I've needed to deal with reablement for an elderly relation. And I can honestly say Libertas have been amazing. And I know we've spoken to them before. I rang them on Wednesday afternoon at the end of my tether. By Friday night, we had support workers in place who were coming 3 times a day. I mean, that is just such wonderful service for the people of Lincolnshire. It was just amazing, and I can't thank them enough. And I think I will be writing in as well, because I know letters are very much wanted, praise for teams. And they've been wonderful, and I can't speak highly enough of them and how they've helped me and my family just lately. So I think this is the right place to mention it, because we've actually had Libertas in. So thanks very much to them.
Excellent, thank you. So, any final comments from anybody? Well, all I can say is I wish you all well in your canvassing, and hopefully there'll be a load of us back next time. I've thoroughly enjoyed this committee, and thank you, Glenn, and your whole team for all your support that you've given us over the last 4 years, and to Derek and his team as well. So thank you all. And I suppose finally, democratic services, because without you, it'll struggle. So thank you all, and I wish you all well.